Good morning, everyone. My name is Kyla Alial from BSN 1A. For today, I'm going to discuss about filariasis. So, before anything else, let's have a icebreaker. Since this is a recorded presentation, pwede nyo na lang pong iswipe yung mga answers. Thank you. So, we're going to move on to the introduction. So, filariasis is a disease caused by a chronic mosquito-borne parasitic infection. Filariasis or filariasis is a parasitic disease caused by an infection with roundworms of the Filarodea type. These are spread by blood-feeding black flies and mosquitoes. This disease belongs to the group of disease called helminthiasis. So, ito po yung example ng picture ng filariasis. And may konti pong description sa baba. So, lymphatic filariasis, commonly known as elephantiasis, is a neglected tropical disease. Infection occurs when a filarial parasites are transmitted to humans through mosquitoes. Infection is usually acquired in childhood, causing hidden damage to the lymphatic system. So now, let's move on to the causative agent of filariasis. So, as you can see in this photo, this is a Brugia malayi life cycle. During a blood meal, an infected mosquito, typically Mansonia spp and Aedes spp, introduces third stage filarial larvae onto the skin of human host, where they penetrate into the bite wound. They develop into adults that commonly reside in the lymphatics. The adult worms outwardly resemble those of Wucheria bancrofti but are smaller. Female worms measure 43 to 55 millimeter in length by 130 to 170 micrometers in width. And males measure 13 to 23 millimeters in length by 70 to 80 micrometers in width. Adult produce microfilariae measuring 177 to 230 micrometers in length and 5 to 7 micrometers in width, which are shattered and have nocturnal periodicity. The microfilariae migrate into lymph and enter the bloodstream, reaching the peripheral blood. A mosquito ingests the microfilariae during a blood meal. After ingestion, the microfilariae lose their sheaths and work their way through the wall of proventriculus and cardiac portion of the midgut to reach the thoracic muscles. There are microfilariae develop into first stage larvae and subsequently into third stage larvae. The third stage larvae migrate through the homuncle to the mosquito's proboscis and make infect another human when the mosquito takes a blood meal. The causative agents of lymphatic filariasis include the mosquito-borne filarial nematodes, Wuchereria bancrofti, Brugia malayi, B. timori. An estimated 90% of lymphatic filariasis cases are caused by um, Wuchereria bancrofti or Bancrofti filariasis. The next slide is the mode of transmissions. So for the mode of transmission, filariasis is transmitted by bite of infected vector mosquito. 2. Parasite deposited near the site of puncture. 2. Puncture skin or penetrate skin. 2. And lastly, reach to lymphatic system. So for the next slide is the pathogenesis and clinical manifestation. So as you can see in this picture, we have the live filarial worms down to lymphangiectasia and lymph vessels dysfunction down to bacterial infection or ADLA. So for the right side, we have the dead filarial worms down to release of Wolbachia antigens. So the release of Wolbachia antigens can also go through the lymphangiectasia and lymph vessels dysfunction. So going back to the right, so down to the release of Wolbachia antigens is the acute inflammation. So bacterial infection LD or ADLA and acute inflammation under that is the lymphatic obstruction. So going to the right, it is the lymph varices. Next is the chyluria. So going down is under the lymphatic obstruction, we have the secondary bacterial infection, going down to lymphedema, going down to long-term recurrent bacterial infections, going down to, or lastly, is the elephantiasis. So, infective larvae from feeding vector mosquito migrate to the regional lymphatic vessels and by including a host inflammatory reaction cause the eventual blockage and edema characteristic of W. bancrofti and B. malayi infections. So for the next slide is we're going to have the pathogenesis. So the first bullet says that due to presence of adult worms in the node and vessels. Next bullet is result from a complex interplay of the pathogenic potential of parasite, the immune response of the host, and external bacterial and fungal infections. So for the next slide is we're going to have the acute stage. First bullet, dilatation of lymphatics. Second is hyperplastic changes in the vessels endothelium. Third is infiltration by lymphocytes, plasma cells, and eosinophils or thrombus formation. Fourth is enlarged lymph nodes. Chronic lesion. The changes include cranial formation, fibrosis, and permanent lymphatic obstruction. Next bullet. Repeated infections eventually result in massive lymphatic blockade. Third bullet. The scheme of subcutaneous tissues become edema to us, thickened, and fibrotic. Fourth bullet, dilated vessels may rupture, spilling lymph the tissues to cause lymphedema and elephantiasis. So, ito po yung pinakita ko sa first picture, yung itsura po ng elephantiasis. Pathogenesis. Disease manifestations are due to lymphatic dysfunction resulting from the presence of living and dead worms, lymph thrombi, inflammation, and immune reactions to worms and worm products. So for the clinical manifestation is we have the asymptomatic microfilariamic, asymptomatic microfilariamic, acute manifestation, obstructive or chronic lesions. Also in the clinical manifestation is the early symptoms of lymphatic filariasis consist of intermittent fever and enlarged tender lymph nodes. The inguinal lymph nodes are very often involve the lymphatic vessels that drain into the lymph nodes and that harbor the developing and adult worms also become inflamed and painful. So, addition to the clinical manifestation is the asymptomatic microfilariamic. The next bullet is the asymptomatic microfilariamic. Under that is the night blood survey. For the next bullet is the acute manifestation. Under that is filariasis fever, lymphangitis, and lymphadenitis. So these are samples of lymphangitis and lymphedema. So as you can see is both are enlarged. So for the clinical manifestation, obstructive chronic lesions, under that is the lymphedema. The next bullet is the elephantiasis, under that is the hydrocoel, elephantiasis of scrotum, pain, leg, arm, vulva, breast, and chyluria. Well, next is the laboratory diagnosis. So under the laboratory diagnosis is the thick blood smear, membrane filtration method, DEC provocative test, 2 milligram over kilogram. So we have the filariasis diagnosis test. First one is we have the blood smear examinations. This is the microscopic examination of stained blood samples. So next is the polymerase chain reaction or PCR. This is the detects filarial DNA in blood samples with high accuracy. So next is the immunochromatographic card test. So this is the rapid and convenient diagnostic tool for filariasis test. Next is the serological test. So this is the detect antibodies produced in response to filarial infection. So next is the seno monitoring. So for this is involves collecting and analyzing mosquitoes for filarial parasite presence. Next is we have the antigen detection test. Antigen detection test quickly identify specific antigens in samples. Next is ultrasound imaging. Ultrasound imaging uses sound waves to produce images of internal body structures. So for the next slide is we have the MF usually in blood. Next bullet is 210 to 320 millimeter in length. Loose sheet which when stained with pale pinky blue and does not stain well. Next bullet is nuclei are discrete and tails and taper evenly. So for the next slide is no nuclei on the tip of the tail. So this is the characteristic of MF of W. Bancrofti. So as you can see there are this wala pong nuclei Um, so nuclei don't go to the tip of the tail. So the parasite is named after physician Otto Wucherer and parasitologist Joseph Bancroft, both whom extensively studied the filarial infections. So for the next slide is we have the treatment. So for medication, you may take antiparasitic medicine such as ivermectin, dityl carbamazine, and albendazole. These drugs destroy the adult worms in your blood or keep them from reproducing. Taking this medicine can also prevent passing the infection to someone else because the worms may still live in your body. You take these medicines once a year for a few weeks at a time. So for surgery, you may have surgery to remove dead worms from your bloodstream. If filariasis caused hydrocele, you may also have surgery to relieve fluid buildup in your scrotum. Next is the elephantiasis management. Your healthcare provider may also recommend strategies to manage swelling, such as elevation or compression garments. So the next slide is the prevention. So for the prevention and control depends upon 1. Mosquito control, 2. Chemotropic control. Under the mosquito control is A. Clinical control by spraying insecticides like DDT, malachon, and etc. B. Biological control by the use of carnivorous bacteria, Bacillus spiratus, strain 1593, carnivorous fish, Bacillus thuringiensis, serotype 11 to 14. C. Environmental control by efficient drainage and sewage system to eliminate the mosquito breeding places. D. Reduction of non-vector contact by use of mosquito nets and house screens. So, normally naman po is, nagagawa natin to. Especially the, reduction of, non-vector contact by use of mosquito nets and house screens. Kasi, siguro naman po is uso yung kulambo. And also the clinical control by spraying insecticides. So, meron naman po yung mga pampawala ng mga mosquito, yung na-spray natin like Baygon. So, for the biological control, hindi ko po, parang I haven't heard from this. So, siguro medyo more on the biologist side po to. So for the environmental control by efficient drainage and sewage system to eliminate the mosquito breeding process. Siguro ito po yung, 'di ba, parang kapag imbak po tayo ng tubig, tapos katulad po sa mga kanal-kanal, is kapag kunwari po, 'di ba, kapag may tubig is napapamahayan po siya ng yung kitikite or yung egg ng mosquitoes. So yun. So, now, we're going to move on to the assessment. So, since yun nga po, ito po ay recorded presentation. So, may mga konting question lang naman po ko dyan. And also, we have the key to correction. So, thank you for listening. I hope you learned something from my discussion. Thank you.